Very good to go.
Okay. So, hello everyone, and very good evening. I am Dr. Ajinkya Nanavare from Emcure Pharmaceuticals. I welcome everyone to yet another interesting session of the No Thrombosis workshop in acute ischemic stroke. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. In the previous workshops, we had a very unique and interesting case discussions, and our total live viewers count in the previous workshop was around 380. So we are looking forward to join more people today as well. And we are also hoping that we will have a fruitful discussion today as well. And it is my honor to introduce our faculty for tonight. So let me share my screen first. So I first welcome our course director for tonight. Just a second. Dr. Subhash Kaul sir. Sir is senior consultant and stroke specialist in KIMS Foundation and Research Center, Secunderabad. Sir has been faculty for more than 27 years at Nizam's Institute of Medical Sciences, Hyderabad. Sir is a former professor and head Department of Neurology as well as Dean at NIMS. He has more than 120 publications in various national as well as international journals. He has been principal or co-investigator of several national and international projects, including the largest single center Hyderabad Stroke Registry, which was funded by ICMR. Sir has won State Teacher Award by Telangana government in 2017. He has been a past president of AP Neuroscientist Association, Indian Stroke Association, and Indian Academy of Neurology. Welcome, sir. Welcome to another session of No Thrombosis. Then I welcome our first moderator, that is Dr. S. Meenakshi Sundaram sir. Sir is senior consultant neurologist at Apollo Hospitals, Madurai. He is a recipient of gold medal and best or outgoing student award for the year 2000 from the NIMANS Bangalore. He has over 20 years of experience in neurology and has more than 36 publications in various journals. Sir has presented many papers at various prestigious national as well as international forums. He has received the Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology. Sir has been principal investigator for many international trials. And he has been editor of the South Asian edition of the book called Practical Neurology. And sir has contributed to many other books on neurology as well. So he will be joining to us shortly. Then I welcome our second moderator for tonight, Dr. Mohan V. Sumedha Madhuru sir. Sir is senior consultant neurologist at Pinnacle Hospital, Visakhapatnam. Sir has memberships of Indian Academy of Neurology, Indian Epilepsy Society, and Indian Medical Association, as well as World Sleep Society. Sir has won 9 academic awards during his whole career, and he has presented at 9 conferences, which has included 1 international conference as well. Sir has more than 11 publications and has won the first prize in clinico-pathological case presentation on thrombotic microangiopathy at MERT 2015. Sir has also won 2 best poster awards and 2 national quiz awards. Sir has been a reviewer to medical journals as well, and he has special interest in neurological emergencies, neurocritical care, neuroimmunology, including the neuro-ophthalmology, vascular neurology, memory and neurocognitive disorders, etc. Welcome, sir. Welcome to this workshop. Then I welcome our first expert speaker for tonight, Dr. Vinit Banga, sir. Sir is Associate Director, Neurology and Head Neurovascular Intervention at BLK Max Super Specialty Hospital, New Delhi. Sir has received the World Stroke Organization Young Stroke Professional Scholarship and also won the award for the best poster at IonCon in 2018. He has won the SN VCon 17 quiz and gold medal during his MD in internal medicine. He has memberships of Indian Stroke Association, WFITN, Delhi Medical Council, and Indian Academy of Neurology. Sir has participated in 14 CMEs and conferences, and had multiple posters and paper presentations as at various conferences as well. Welcome, sir. Then I welcome our second expert speaker for tonight, Dr. Varun Rehani, sir. Sir is consultant neurologist at BLK Hospital, New Delhi. He has won the first prize for the best award paper presentation at 23rd Annual DNA Con 2021. He has also won the second prize for the poster presentation at 69th Annual Conference of the Association of Physicians of India. He has participated in 10 CMEs and conferences and has had 5 presentations at various scientific conferences. Sir has published 5 articles in various journals and has expertise in acute stroke management with IV thrombolysis, mechanical thrombectomy, status epilepticus, myasthenia crisis, and GBS. Sir has also experience in dystonia, Botox injection for various movement disorders, and chronic migraine. Welcome, sir. So with this introduction, I would like to hand over this session to our course director for tonight, Dr. Subhash Kaul, sir, for his context setting and opening comments. Dr. Kaul, sir, over to you, sir.
Yeah. So thank you, Dr. Ajinkya, for giving an introduction of the course and today. And as you know that every month we cases, and we believe that each case, each patient is different from others. Therefore, it throws its own unique challenges, which may not be captured in the guidelines. And such kind of outliers are never discussed anywhere in any. It's a good forum where we learn from each other's experience and share about it. In fact, only yesterday I had a patient who was 85 years old patient, and he was on double antiplatelet, and he came with acute stroke. So wondering whether I should thrombolyze him or not. And he was within window period. And I always thought that tenecteplase dose in our country is less than what is actually recommended internationally. It's 0.2. That is internationally, it's 0.25. But because it's in the guidelines, so we give 0.2. But for once, I was happy that the dose is 0.2, because that way I would be giving less dose to this patient, because I was afraid of his bleeding complications, being 83-year-old plus on double antiplatelet. So here I was satisfied that, okay, 0.2 is safe for him, and we are still within the guideline. So each patient is different, and each patient needs a different treatment. So I welcome today's moderator. I think Meenakshi may take some time to join, but Dr. Mohan Matharu and our presenters for today, Vineet and Varun. So with that, I will request the moderator, Dr. Matharu, to begin the proceedings. Introduce the speakers. They have already been introduced, but invite them to present there.
Good evening, everyone. I think the number of participants are a little less. I think only the moderator, speakers, and the organizers are here. I think nobody has yet joined. It is actually my great opportunity to speak alongside all the course moderator, the director, who has been head and a very well-known personality in neurology in Andhra, Telangana. And with respect to the speakers, Dr. Varun, it is a good opportunity for us to learn from you as well. And so I think we'll start the session because it's already time. Yeah, Dr. Varun, please proceed.
Yeah. Dr. Varun, sir, you can start with your presentation.
Okay, I'll start.
Just a one point, sir, Matharu sir. We have only these moderators and speakers, and Dr. Course Director will be joining here. And this program is live on YouTube as well. So all
Okay.
the participants are gonna watch us live on YouTube, and they can ask any questions in the comment section as well.
Okay, so that's good to know. Okay, thank you.
So, with your permission, I'll be starting. And I would like to thank the Emcure Pharmaceuticals. I would like to thank Dr. Subhash Paul, sir, and Dr. Matru, sir, for allowing us with this opportunity to have another detailed discussion on cases on stroke. And as sir has said, we should discuss on cases which are like the outlier cases. And similarly, I'm going to present a case uh, which I had encountered during my last month of residency. So this was stroke in a young soldier while I was working in the Army Hospital, a research and referral hospital, RNR in Delhi. So this serving soldier, a 34-year-old male, right-handed, who was posted at military hospital Meerut with no known comorbidities, was a resident of Delhi, suddenly developed at 11:30 hours weakness of the left half of the body with deviation of the face towards the right side and difficulty in speaking. On the same morning at around 700 hours, he suffered a minor accident in which, while opening the door of his car, he injured himself over the right side of the neck, causing a superficial cut. After that, he was doing well and had no other complaints other than the local side area of pain. At around 11:30 hours, he suddenly developed left hemiplegia with deviation of the face towards right and difficulty in speaking. He had to be brought in a stretcher and was not able to move the left half of the body and reported an emergency within 2 hours. Other than the history of trauma, there was no preceding history of headache, fever, seizures, any chest, any cardiac symptomology symptoms, any history to suggest immune physiologies, any history of a visit to high altitude. So this was a common history that we had to ask in our patients because there's a very high incidence of CVT in our patients who work in the high altitude. Any history of any drug intakes, any history of past recurrent swelling of legs, or any previous histories of TIA or stroke, and he had no comorbidities. He did not consume alcohol, was a non-smoker without any history of high-risk behavior. On examination, his pulse was 80 per minute. It was regular with normal volume and character with all peripheral pulses and carotid pulses also present with no carotid bruit or tenderness. The blood pressure was a little high, 140 by 88 with a glucose of 110, and there was no other findings on the general physical examination. On neurological examination, he was disoriented. The GCS was 14. There was partial gaze palsy. There was a left human facial palsy. He was able to answer questions. The power on the left side was 0/5, and there was also mild sensory loss. The NHSS code was 14, and other systemic examinations were normal. Patient was immediately taken up for an NCCT head with a door to imaging time of around 25 minutes. And it was noted that there was no intracerebral bleed. There was a right hyperdense MCA. There was right insular ribbon sign and an aspects ratio, which was around 7. I do not have all the cuts, but the aspects was around 7. Since the patient was in the window period, the patient was thrombolized with tenecteplase with a weight of 80 kg. He was given a 20 milligram of IV bolus dose, which was usually given outside the radiology department. And it was given after Foley's catheterization, and it was given within 40 minutes. The door to needle time was 40 minutes. Patient was shifted again and for the CT angio and perfusion studies. And the CT angio showed a possibility of a dissection over the right ICA and also showed a right MCA M1 complete cutoff. The perfusion scan, as we can see on the MTT was prolonged in the right MCA territory, and the cerebral blood flow and the cerebral blood volume was also compromised. It was reported by the radiologist as having mild perfusion mismatch, but since he was a serving soldier, all modalities of treatment were being considered, and the patient was offered mechanical thrombectomy. DSA, patient was shifted for DSA, and it showed that there was a right ICA occlusion, and there was at the origin, there was a flame shield configuration, which suggested a dissection. The dissection flap was crossed with guide catheter, and the cervical ICA DSA, it showed sluggish flow and patchy occlusion distal to the supraclinoid segment with a complete M1 occlusion. The thromboaspiration was done. However, the procedure was a little difficult, and it was done over 8 hours for the occlusion, after which complete flow was achieved. For the ICA dissection over the proximal ICA, the stent was placed, after which there was complete opening of the right ICA, MCA, and ACA with good angiographic results. After the intravenous as well as the EBT, patient was shifted to the ICU and kept on ventilator, was managed with anti-epileptics, statins. However, the next day patient became increasingly drowsy, with the right people showing sluggish response with normal size. And on the second day, the NCCT had shown a hypotensity in the right MCA area with a midline shift. There was a dip in consciousness. There was, despite all the procedures, the patient had developed malignant infarction. However, there was no ICH. Patient underwent a right frontotemporal, right frontoparietal decompressive hemicraniectomy with bone flap in the abdominal wall. Post-surgery, patient was managed with LMWH at DVT prophylaxis and ecospin at 75 milligram via Ral's tube. Post-operatively, the CT had shown improvement of the mass effect and the midline shift. The patient was on ventilator and subsequently tracheostomized, was managed for ventilator-associated pneumonia. All the other causes of cardiac, vasculitic, prothrombotic workup were negative. Patient had gradually shown improvement over 7 days and had become completely conscious. He was discharged with a temporary medical category at 3rd week of illness in a MRS 4 stage. He was given 8 weeks of sick leave, and he was given discharge on dual antiplatelet. Post his sick leave, patient was readmitted. Patient had recovered well, and tracheostomy closure and cranioplasty was done at the end of the 2nd month. That was around almost 12th week. And after another spell of sick leave, he had returned, and this was his clinical status, in which the patient was mobile, able to walk without any support, and was able to perform his activities of daily living. He was thereafter given a permanent P2 category. Coming briefly on dissection. Spontaneous dissection is a common cause of stroke in young, which is seen in approximately 10 to 20% of all these young ischemic strokes. Among these, extracranial dissection is far more frequent than the intracranial dissections. The neurological damage or the sequelae that may arise out of dissection may be because of thromboembolism, may be because of hypoperfusion, or local symptoms that may be caused from compression of the adjacent nerves and their feeding vessels. In our case, most likely there was a thromboembolic pathophysiology that led to sudden deterioration, that despite having done major things, all the things, the patient had a initial poor outcome, but a long-term delayed outcome at 3 months was relatively well achieved. Thrombolysis, as we know, is effective and safe, but in dissections, especially in aortic dissections, it can cause complications. So this was one of the initial statements that was given by 2019. MT and intra-arterial thrombolysis may be treatment options at expert centers, but should not preclude thrombolysis therapy for otherwise eligible patients. Till 2019, the antithrombotic rule was to either give antiplatelet or anticoagulation for patients with ischemic neurological symptoms caused by extracranial dissections, and antithrombotic treatment should be delayed until 24 hours after the thrombolytic therapy, but can be started immediately for those who are ineligible for thrombolytic therapy. And as per 2019 guidelines, IV alteplase was found to be safe for extracranial. For intracranial, there was unknown evidence whether it is safe or not. And the duration of treatment, as I stated, was for 3 to 6 months. However, now as per 2021 AHA guidelines, it states that we should treat with antithrombotic treatment for at least 3 months. with either aspirin or warfarin. And we should consider for endovascular therapy in patients with recurrent events despite antithrombotic therapy. And as per the European guidelines, it states that for patients with aortic arch dissections who have come in the window period within 4.5 hours, they recommend that no IV thrombolysis should be done. Why? Because these patients are at high risk to develop cardiac tamponade, pericardial hemorrhages, intrapleural hemorrhages. For patients with cervical artery dissections, isolated cervical artery dissections, that is in our case, it is suggested for intravenous thrombolysis with alteplase. For intracerebral, for the intracranial one, as per the expert statement, they advise against intravenous thrombolysis because these patients are at higher risk of bleeding because of lesser covering of the vessel wall. Therefore, they may have risk of SAH. The endovascular treatment, I have stated, the role is dependent upon the recurrence despite treatment, and the options are of angioplasty, stent, or embolizations. There are no randomized trials data which compares endovascular techniques with medical therapies, and the long-term safety and durability of these methods are unknown. Overall prognosis for the dissections, they usually have a good prognosis with 70 to 85% have shown excellent recovery. However, 10 to 25% develop major disabling deficits, and death can be a cause, can be seen in 5 to 10% cases. So what the learning points? Learning points is that tenecteplase in patients with cervical dissection, although not recommended, was relatively safe. It was not associated with any hemorrhagic complications. And considering a mechanical decompression in a young patient should be considered early for early recovery. Thank you.
Yes, Dr. Varun.
So,
This is a very nice case which you have presented, and the patient had achieved a very good outcome, functional recovery. He was able to walk independently. That is very significant improvement. I agree with it. And two points I would just like to make a clarification. Initially, you had mentioned that the plain CT was done, and you had given the bolus dose within the radiology console itself. So after that, the patient was shifted again for a CT angio. So because usually when we develop stroke centers, it is very important that we give the bolus dose within the CT console where the patient is getting the scan done, because it's the shifting period. It's a time waste. But I would suggest before giving the bolus dose, it would have been better if you had done the CT angio also in the same setting, because just like this patient where you have noted that there is a cervical dissection, it so happens that in young patients, especially when there is vascular abnormalities like collagen deficits, where you can expect multiple level dissections, possible aortic arch dissection or an intracranial dissection as well. Then the risk stratification for respect with giving IV alteplase or a tenecteplase, it changes, because as you had rightly pointed out in the evidence that intracranial dissections, the data is unknown, but in cervical dissections it is safe. With respect to aortic dissections, it is contraindicated. So we would have given it would just take hardly 2 minutes time in order to get the CT angio done at the same setting. So I would suggest that, because I'm telling these points because I'm practicing in Visakhapatnam, and the place where I've shifted recently, we are trying to develop a comprehensive stroke center. So these are the practical difficulties that I have been facing, because in practice, everyone here is much more trained with respect to MR thrombolysis. Giving a CT thrombolysis is something which is new, which is time saving and more effective. So just like you had pointed out, the second point is that early decompression would be beneficial. So that is one thing here. We find practically it is difficult, because giving alteplase patients, we would counsel in such a way that the benefit would be there. That is the reason that patient relatives usually go ahead with tenecteplase or thrombolysis. But after that, when we don't expect the adequate outcome, after that do mechanical thrombectomy, the financial issues will usually start. Second, immediately on the second day or the third day, if you tell that the procedure has failed and then you would have to go for a decompression, it is very difficult for the patient relatives to accept that they had spent so much of money despite which there is no adequate outcome, and they would start blaming the doctor or the center where this and all those other aspects which start on.
True,
But
absolutely.
it is very good that you were able to do that and you got a very good outcome.
So,
The other practical issues that I would just also want to share is even though when we give thrombolysis, even though you had given the agent at this exactly within the window period, your door to needle time of 40 minutes is exceptional, because when we start a new center, usually here in the last 6 months, initially our door to needle time was around 50-55 minutes. Later on we were able to slowly streamline the things, and then we were able to come down to around 40-35 minutes. 35 minutes was the best that we were able to give, but still the consent issues, patients making consent delayed, all these come into picture. Even though we give it within the window period, the initial agent, and then we do a bridging or in only thrombolysis, the first 24 hours post thrombolysis, the management of the patient in ICU, the BP targets, the glycemic index, temperature regulation, the electrolyte monitoring, all these things will definitely play a role in the neuroplasticity. So even though what in my personal experience, what I had noticed is my colleagues, because earlier it was all alteplase. Now only when in the last 3 years that we had changed our practice from alteplase to tenecteplase. So once I had noted that tenecteplase is non-inferior and the number of hemorrhagic conversions are less, and it is practically much more easier to give a bolus dose, I've asked my colleagues also to try to start changing from alteplase to tenecteplase. So what they had initially noticed is that tenecteplase, they were not getting adequate benefit, but that is what it is contradictory to what we are noticing in the evidence and what I got. So when we started discussing, it was what I was able to get is post tenecteplase, either the BP fluctuations or the temperature management or the glycemic status that was not adequately controlled in those patients. Most commonly in diabetic patients after tenecteplase and due to the acute stress because of stroke, the glycemic, there will be hyperglycemia. So you should have lower threshold to start insulin. You start an insulin infusion immediately post tenecteplase so that the glycemic management is very important. So first 24 hours post tenecteplase would also makes a major impact on the functional recovery later on. These are the things that I just wanted to add. I think if anything else, the other moderators or Dr. Subhash sir would like to add, we can. Otherwise, we will proceed with the second speech.
I just want to make one comment.
Yes,
I agree with all your comments, Dr. Sumedha Matru.
Yes.
And Varun, you did a good presentation.
thank you, sir.
What I heard is that immediately after the thrombolysis and the stenting, he was on double antiplatelets or single antiplatelet? I heard
He
single.
was only on single antiplatelet and a DVT prophylaxis dose of LMWH. He was discharged on 3rd week of illness and on dual antiplatelets.
But what was the rationale of putting him only on single antiplatelet? Because usually after stenting, patients are put on dual antiplatelet.
Because the patient had undergone decompression and because of the local area of bleeding, sir. That was the only reason why we had withheld.
So, yes, that's true. But you also, when you do that, there is also a risk of stent thrombosis. So you have to constantly balance both risks, the risk of bleeding as well as thrombolysis, which you did, and I think it worked well. Sometimes we have to do it. Even sometimes in stenting also we have to give a single antiplatelet, but there is a risk of stent thrombosis. And the second thing is that in the same context, I have also seen patients who, after a similar situation, I remember them, and I'm sure you must have seen patients getting a hemorrhage, massive hemorrhage, in fact. And one of the causes of the massive hemorrhage is the big infarct size. Second is the reperfusion injury. And in this kind of a situation, precipitated by the dual antiplatelet. And that is why people don't, many times they are hesitant to put a stent in the acute stage because of the requirement of dual antiplatelet. But there are situations when you have to do it. So therefore, one of the via media which works in some situation and not all is that they do only angioplasty without stenting. But that doesn't work every time, because I know many times they do angioplasty, it again collapses. So therefore, they have to do stenting. So I think same might have happened in your case also. Particularly dissections, I think they collapse.
Yes, sir.
The angioplasty doesn't hold. So therefore, you have to put a stent. And one last comment is that is actually to, I think you only said that. I mean, this is absolutely as per the guidelines, aortic dissection is a contraindication, right? Absolute contraindication. In fact, carotid dissection also used to be a contraindication for the first 10 years after erythropoiesis, but now it has been removed. But you will be surprised if you look in the literature, there are aortic dissections also which have been thrombolized as case reports. So
Yes,
that is the way. That is why they are case reports. They because sometimes you don't know that there is aortic dissection. I mean, if you see for giving IV TPA, the recommendations don't say vascular imaging has to be done. Recommendations say only CT scan. That's all. We do this mechanical. We do this vascular imaging for doing mechanical thrombectomy. But for IV TPA, it's not a requirement. Therefore, it's quite conceivable that sometimes we will be missing. And those cases are in the literature. If you see that there was a patient with an acute chest pain, it was thought as a MI, and in fact the cause of MI had turned out to be underlying dissection, and they did well eventually. But for guidelines, I completely agree with you that when we know it's a dissection, we should not give it. But the point I want to say is that even dissection people have sometimes survived IV thrombolysis, aortic dissection.
Even I have looked up in that literature.
So, but anyway, great case, and I think nice discussion, a lot of learning in this. Thank you very much.
Thank you, sir.
So, sir, we can move to next case.
Yes.
Yeah. Dr. Vinit, sir, can share his screen.
Has Meenakshi joined or not yet?
No, sir, not yet.
I think patient is serious.
Yeah,
ICU.
Yeah.
Can you see my screen?
Yes, sir. Sir, you can switch to slideshow mode from the first slide. Sir, your voice is.
You're on silent mode.
Dr. Vinit, sir, you can switch to full screen mode or slideshow mode.
Am I audible?
Yeah,
Yes.
you are audible now.
Are we audible to you?
Thank you, sir.
Can you please shift the stress? Yeah, great.
Yeah. So I was wondering whether I'm audible or not. Sincere apologies for logging in a bit late and then getting disconnected because of some network issues. At the outset, I'd like to thank Emcure as well as everyone available, especially Dr. Kaul sir. He has been such an inspiration for people like us for so long, and it's indeed a privilege to present in front of him as a speaker. So I would present two cases which made me think about endovascular management in acute stroke patients. So I'll begin the first case. So the case starts with a 62-year-old female, a home manager by occupation, and she was a diabetic, hypertensive, though well controlled. She used to live at home, and the husband and the wife, they did not used to talk much. So in the morning, the husband left home for work and leaving her asleep at around 8 a.m. When he came back at 9:30 p.m., he find her in the bed, undressed, and he found that she was not moving the right side of the body and she was not able to speak. Within next 1 hour, she reached to our hospital. When we examined the patient, she was having right hemiplegia, expressive aphasia, and was having complete facial paralysis. The NIHSS was 14. So the provisional diagnosis that we had was partial anterior circulation syndrome, left MCA syndrome. But we were not sure about the window because the husband left at in the morning around 8. So whether we should consider it a wake-up stroke or whether the patient had stroke in between from morning 8 till evening. So we didn't know the exact onset of the stroke. So we thought, and we thought about it. We thought, let's apply our brains into it. But before we did that, we were thinking and we went ahead with an MRI because we were not very sure about the onset of the stroke. So in those cases, when we think that the onset is not clear, we sometimes get the MRI. So in MRI, we found that the patient has a left MCA territory infarct, which can be seen involving of putamen, posterior part, periventricular caudate lobe, and this was the diffusion and this was the flare. So there was no diffusion flare mismatch. But what we also saw that there was prominent blooming of the prominent and on the veins of the left side when you compare right and left on the left side. So it means in itself there is a large vessel occlusion and there is a penumbra probably, because even seeing the prominent veins in GRE is a surrogate marker for perfusion deficit. So what should we do next? So there is no diffusion flare mismatch. So, and the patient is of unknown time of onset. So definitely the patient is out of window for thrombolysis. So now, because we considering that she has a large vessel occlusion, whether we should consider mechanical thrombectomy or not. The second question was, what was the window? The third was, what are the guidelines? So we thought about the window first, and the circumstantial evidence was in favor of stroke after 8 a.m. Now, why is it? Why was it? Because if the patient had undressed, she was half on the bed, half on the way down. So probably she went to washroom to pass urine. And while she were coming back, she could not undress herself. She could not dress back. So that was the circumstantial evidence that we had, that probably this stroke onset was not before 8 a.m. It was not a wake up stroke, but it was after 8 a.m. when the husband left. So even then the windows is around 15 hours. And then the windows of 15 hour, then we can at least use dawn and diffuse. If we consider this as a wake up stroke, then this patient is out of window of dawn and diffuse. So we decided, okay, we are not very sure whether we would save anything. So we decided, okay, let's get a CT perfusion. But it was our bad luck that the patient moved during CT perfusion. But we could definitely have CT angio and aspects. So this was the diffusion. This is the clot you can see on the diffusion. This is the CT angio reconstruct that we made from the perfusion imaging. And this was the aspects. So the patient had a relatively good aspect, and to add here, we only do CT perfusion as the imaging in patients who present early. So this was an outlier case where we did MRI. but we only do CT perfusion. We do aspect scoring on base or source perfusion images. We reconstruct CT angiography through perfusion images. So the only imaging that we use in emergency is a CT perfusion at present. No CT, no CT angio, just a CT perfusion, 3 minutes protocol done. So if you see, CT perfusion source images are very good when you think of aspect scoring. So you can see like part of the left MCA cortex here at the ganglionic level as well as the supraganglionic level is gone. So whether all of this is infarcted or not. Now, if you compare this aspects of CT to this MRI, there is a mismatch. We don't see any diffusion restriction in the higher frontal cortex. But this CT scan, this aspect score looks a bit high. So this was it. So there is discrepancy between MRI and the CT. CT was showing a lower aspect while MRI was showing diffusion restriction in a higher number, in a lesser cortex. So if you do an MR diffusion aspect, it will be much higher than the CT aspect. Here the CT aspect will be like around 5, but an MR aspect would be around 7. So there is a difference between MR and CT. So I would like to ask probably later, what is the aspects as per the team? So, and whether we should do mechanical thrombectomy or not. So now we know probably the window is around 15 hours. We have a large vessel occlusion and MCA occlusion, and the patient has a diffusion clinical mismatch or a perfusion which was not done. So we considered if the patient doesn't have a diffusion flare mismatch, it's very unlikely that the patient is going to progress. So we decided, okay, like we are still not sure whether we should do for mechanical thrombectomy or not. We thought maybe she is having ICAD with very good collaterals and is it less likely or likely to progress or evolve? Because usually in these cases, the patient usually has a diffusion clinical mismatch and a diffusion flare mismatch. If the diffusion and flare are matched side by side, it's unlikely that the stroke will progress. But whether it is an ICAD with good collaterals or was it, so we decided, okay, we'll ask the family how to go about it. We told them about our doubt and we told them that we want to check for the collaterals and then probably go for MT. The family agreed for mechanical thrombectomy. We took up the case, but we decided we'll check the collaterals first on table and intervene if the patient has a poor collateral. And this was the first DSA. This is the vertebral run. If you see, vertebral is filling PCA and through that ACA, but it is not very brisk collateral flow. If you see the MCA, the right MCA is not perfusing the left MCA territory at all. So overall, it's a poor collateral system with 15-hour window. So we decided, okay, let's go for mechanical thrombectomy because this patient is most likely to progress in the time. And what his CT aspects look at present, probably his MR diffusion will be the same after some time. So we did the mechanical thrombectomy. The patient did fine. And this was the CT the next day. If you see, there is like bright, shiny things. This is because of contrast staining because this was done the next day. So this is the dead tissue. Part of it here is the dead tissue. But if you see higher frontal cortex, quite a lot of it is saved. So all of posterior temporal cortex, all of high frontal cortex, all of temporal cortex is saved. So I'll begin the second case. And
no, I think why don't we? Both are similar, but then we'll forget about this case, no?
Okay, sir. So can we discuss it now here?
Yeah, if it's okay with you.
Yes,
because,
sir. Sure.
Because otherwise we'll forget about this. Now, I think it's a great case. I'll just ask some queries and then others can also ask. And fantastic. You see, the first thing is that when you, how do you say 15 hours? When was she last seen awake? When was she last seen awake? How many hours before?
She went to bed with her husband around 10 p.m. the previous night.
Yes.
When the husband left home the next morning around 8,
Yeah.
She was lying in the bed. She was sleeping in the bed.
Yes. Yes.
And
She might have had
because
stroke. She might already have had stroke, no?
she might have a stroke. So we were not sure about it.
So that means, no, usually conventionally speaking, the window is calculated when the patient was last seen, awake. So if we go by that, then how many hours it would become? Even
So
more than 15 hours.
it would be more than 24 in that case, sir.
Yeah. Yeah. Now, but we are not sure. You are right about that. So this is one thing. In fact, there is another. If you have seen in these new guidelines, European guidelines, they say if the patient is less than 9 hours from the middle of the sleep, you know, so they assume that what time the patient has gone to sleep till that time, and if you take the half of it, it should be less than 9 hours. So much calculations people do. But we are not sure about it. It may even be more than 15 hours. So that is one. The second thing is that, in fact, when you showed the MRI, from the MRI only, I did not see very good collaterals there. I did not see on the MRI only, not see I did not see very luxurious collaterals there. So I was expecting that the collateral will be poor. But the best thing which I like in this patient, and I really, that is something to learn. I often say that these interventionalists, they choose their patients on seeing good collaterals. And I have always wondered, why do they ask for good collaterals? It's the bad collaterals where we should show urgency, because good collaterals, anyway, they are there. They are also, you can prognosticate he will do well, but they say, okay, many times they drop the patients thinking that there are poor collaterals. And I think you have very nicely shown that that became your selection criteria, that there were poor collaterals. So that is great. I think that is some point which is really worth learning, and the patient did well. Thank you. I think we can ask other participants to give their comments.
Dr. Vinit, this is a very nice case that you had chosen to present and share with us. I'm so happy to have listened to this. And the main thing is that the patients who have clear-cut criteria who satisfy, it is nowadays easy for most of us to treat. It is the outliers that make us learn things and that show our expertise to the entire world. So this is a very classical case of an outlier where we don't have any proper guidelines. And this is where your team effort would show. And all the more you had told that here, because of the collaterals that you had chosen, collaterals in acute settings, to choose an intervention is very important. Now, these days, the importance of collateral should be highlighted, because most of them, they don't give much importance to collaterals, as Dr. Subhash sir has already pointed out nicely. And one more thing with respect to this patient, what about the clinical outcome? Here we are able to save the cortex majority, but still the core, the capsular ganglionic area is still infarcted to the core. So what happened to the clinical recovery of this patient? May I know?
So I'll tell you, I got a promotion because of this patient. So this patient was a very good friend of the CEO of the hospital, and
Great.
she did very well. I got an out-of-turn promotion, out-of-turn salary hike. And so she is still walking, doing most of the things independently. And like she can walk around. Her power in the hand is still not back to normal. It's around 4 minus by 5. But she's walking, she can talk, she can walk around, and her lower limb and everything is normal. Now, what I feared was that if we don't do anything, it will eventually turn out to be a malignant MCA infarct.
Yes.
Because the area in that MCA territory was showing bright in venous, in GRE images, it was showing the venous congestion. So that was one of the things. The second thing was that if you see, the discrepancy was between the aspect scoring. So I'll go back. If you see, this aspect looks very bad. So if I'll show you this aspect, and if I'll ask you whether you will do mechanical thrombectomy or not. So you look at this area is gone. This area is gone. This area is gone. So his aspects is probably less than 5. But if you see the MR diffusion aspects, it was very good. So it
What was the
only
gap
7.
of time? What was the gap of time between
Sir,
MRI and CT?
Sir, almost 15 to 20 minutes. And CT was done after the MRI. And when we compared the day 1 CT, it was more in line with the MRI than with the CT aspects. So sometimes even so this was the CT aspect over assessing the infarct core, and the same way CT perfusion over assesses the infarct core. So we did not have a perfusion match here. The CT aspect was standing itself for the perfusion for the core. So probably even if we would have had the perfusion maps with us, it would have over assessed the infarct core and probably would have led us to go against mechanical thrombectomy.
So
Luckily, we did MRI in that case.
So did you do the post-procedure, what was the post-procedure imaging done? Post-procedure?
Sir, this was, sir, the next day.
Which was that, CT or MRI?
CT, sir.
This is the one?
This is the one, sir.
So which means you see, this is the MRI people will be very happy to see this presentation. This is what the MRI people say, that MRI gives you a more definitive idea of this infarct rather than CT scan, in which there's a margin of error. Although I know the CT lobby does not agree with that. They say, no, your eyes have to be good, you can detect it. But this is a good example to show that how the CT can sometimes not give you accurate assessment, but MRI will always give you.
I would actually add a small thing, sir. Actually, when the aspects was introduced, it was mainly to use a CT as an imaging criteria.
That's true.
So the MR aspects is actually an extrapolation of the CT aspects, but the original imaging that was used to calculate or to develop the aspect score was CT only.
Correct.
So here, as Dr. Vineet had initially told, that there is possibly that if at all we do not have intervened, the infarct core must have increased. So because we had intervened at that point of time, the post-operative CT was almost matching the MR, because MR already had created a core, and whatever the perfusion CT perfusion was giving is still in the penumbra zone only. That was the reason that was why it got saved when we did a revascularization here. So that is the reason post-operative CT is almost matching MR. It's not that CT is overestimating.
But Sumedha, I have one point to that. I agree with you.
Yes, sir.
The perfusion deficit can be reversed by our mechanical thrombectomy.
Yeah, yes, that's
but that CT scan hypodensity cannot be reversed. That obviously was an artifact. What do you say?
Exactly. So that is why I chose this case. This is one case where there are so many discrepancies. We don't know the window, and there has been a discrepancy between CT aspects and MR aspects. So which one would you choose? So here the CT aspects has over-assessed the infarct core. We are not talking about CT perfusion. We are talking about a base CT aspects here. So CT aspects has now probably over-assessed the infarct core. And here, if you see, if you calculate the aspect score, it's poor aspect score. It's almost equaling to 4.
No, I know, but I mean, if you look carefully at this, no, I know you cannot see my arrow because you can move the arrow. If you see carefully within this hypodensity, the core is still seen. It is more blacker than the rest of it.
That's what I was able to. The core is already the
probably
MR.
the rest
MR
of it is not.
Because what we are seeing is actually a source image of a perfusion scan, right, sir? So it is not equivalent to a plain CT aspects. It is a source image of a perfusion, where we know that perfusion is always better than plain CT in assessing the hypodensity or early ischemic zones.
But the take-home points are very good. I mean,
yeah, that's good. So that's
we have to look carefully at CT scan.
We did the CT repeat also. I don't think I have it here. I haven't kept it for the want of time. But the CT, the third day CT, the fourth day CT, whenever we did, it absolutely matched the MR. Absolutely. Point by point. There was no extension at all.
That shows how successful you are in managing that in the setting.
Yes. If you had not intervened, the whole thing would have.
Yes, that probably would have. Yes.
Great.
So I'll begin the next case again.
Sir, excuse me. Sir, namaste, sir.
Hello, welcome, Meenakshi. We are missing you.
Sir, I joined a little bit earlier itself, sir. I was just waiting. Sir, can I have
So
a small comment?
did you attend
Yes,
this
sir. I
case?
heard the
The
case.
case. So
Yes,
please give your
yes,
valuable
sir.
comments.
No, sir. From the middle of it, I attended, sir. I couldn't attend from the beginning. I was held up in the emergency, sir. I'm so sorry for having joined
So
late, sir.
you're the real
Sir,
stroke doctor.
no, sir. Sir, very sorry, really, sir. Sir, the point I was trying to ask is that earlier the aspects, as you were saying, as someone was saying, aspects was defined from the CT, and the CT6 is what we were actually using earlier, and then MRI people said it has to be 5 for MR aspects. And now there were two important data which came from the rescue limit Japan trial, then the select 2, and then the angel aspect. Now I believe that interventionalists are okay by doing up to aspects 3. Am I correct, sir? Less than 3, they don't touch. The core volume 50 to 120, still they are doing it. That's what our interventionist has actually told us. Because now earlier, if it is poor aspects, we won't touch, because ultimately the results will be poor. But now the concept they are saying is that even if it is a poor aspect, without treatment, they will do very badly. It is better to take up for intervention. Probably Vinit sir has taken it on that grounds, I think. Is that correct, sir?
No, so like this patient was before these trials, and I do beg to differ with regards to the new trials. I am a strong antagonist of these large core trials because of a simple reason that the good outcomes were 20%, only 20%. So if we do large core trials in India, especially when the patient is paying, it becomes a major problem. For example, I don't extrapolate those trials into my practice because the patient has to pay from pocket. In the Western world, because the patient is not paying from pocket, even if you save mechanical thrombectomy, it's good. In a country like India, so it's something very subjective. I would say, like, you can say that I am not talking about science and I am talking about personal experiences. Partly yes, but if you do mechanical thrombectomy in a private care setup and the patient undergoes decompression and eventually doesn't walk back home or doesn't improve over 3 months, then it's very difficult to counsel the family. And I have been always a strong antagonist of extrapolating these large core data in Indian settings, especially in private setup where the patient has to pay from pocket. So this patient I have selected before these trials come, but I have selected based on MR aspects and not on based on CT aspects. So even today, when the CT aspect score is below 5, I usually avoid doing mechanical thrombectomy because these patients tend to do very bad, and usually they need decompression, and overall only 20%, even the trials have showed only 20% have done good, so 80% don't do good, so majority doesn't do good. Now you compare this 20% versus somebody who is not done mechanical thrombectomy at all. So yes, it's a good number, but when you compare 80 and 20, it doesn't look a very good number, it looks a bad number in fact. So when you compare 20 to 0, it looks good. So it depends upon how do you see it, from which angle are you seeing it. So from where I see it 80 versus 20 rather than 20 versus 0 or 5. So from my point of view, I'll never touch a patient who has an aspect score of less than 4 unless that patient has a right MCA territory involvement, unless that patient is young. And the third and the most important criteria is if the patient has to be very nice, very accepting, very understanding.
That's a
Otherwise, it
great
becomes
lens.
very difficult.
And the fourth, if somebody else is paying for him.
True, sir.
Sir,
True. The government panel
there,
patients, probably.
sir, the point is, when we were using earlier the NIHSS stroke scale, we were telling the same thing, that high NIHSS do not thrombolyze when we are starting our IV thrombolysis. But now that criteria has been walked over, because now we say that even if it is a high NIHSS, you do it because otherwise you do it for us. In your own scenario, what would happen to these patients if you had not intervened in them? They would be anyway ending up with the decompressive surgery. Even without your intervention, the same should be true. Of course, they were not paid an extra amount for the intervention. But wouldn't it be okay to give the choice to the family than we telling that, sir, when we have data up to 3, we can do it? What is your take on that, sir?
So I give the data. I tell them 20% versus 5%. So that's my data now. But I think when you are standing in emergency, it depends upon how you counsel. So if an interventionist really want to do it, he'll counsel in a way, the numbers can be projected in a different way, on different, emphasizing on different ways. So I am yet to find a patient who has refused mechanical thrombectomy. So I have done maybe 200 mechanical thrombectomies by now, and I am yet to find a patient. Only 2 patients have refused mechanical thrombectomy till now. And the same way, if I counsel them the opposite, they have never agreed to it. So I think it's about the person counseling, and it's about you convincing yourself. Whether you want to convince the patient, you have to be convinced first. So for large core, probably I am not convinced. So I've never been able to convince the family as well. So that can be one of the reasons, but I give them number. So in large core, in a small core, I give them 70% versus 5%. Now here I give them 20% versus 5%. So that's how I go about it. And most of the families, they are a bit, when you tell them you have to spend 4, 5, 6 lakh rupee in the middle of the night, and you give a number of around 20%, most of them don't agree to it. If they are not paying from pocket, all of them agree to it.
Yeah. So I think we all agree with you. So can we come to the second case, because it's already 9:03?
Sir, sure, sir. So this 60-year-old female homemaker by occupation had a history of diabetes which was uncontrolled, and she was having a Gurbani part at her home. And suddenly, while doing prayer, she found that she was unable to stand up from sitting position. The family also noticed some difficulty in speaking along with right-sided weakness. While she were on the way to hospital, she was already better. The weakness improved. When we examined the patient, there was only minor right hand grip weakness and minor facial palsy. And NIHSS was 2. And this was the CT. So the CT looks good and aspects of 10 almost. And this patient has a low NIHSS. Now, the question is whether we should thrombolize this patient. The patient has a low NIHSS and an improving weakness. And whether we need more information. So what is the opinion of the house? Whether all of you will thrombolize, or you will wait, or you will read more information? What else do you need?
Meenakshi.
Sir, I will thrombolize.
Yes, I will also. I have
Both in
thrombolyzed such
stadium,
patients. Yeah.
without hesitation, sir. I have.
So I do agree
It is
to
one word
both
voting,
of you.
yes.
We decided, okay, let's have some more information because it's a low NIHSS window. So we did do a CT perfusion base image. We did an CT perfusion. So as I told you, we do CT perfusion for all our patients because it takes only 3 minutes extra. So we do a CT perfusion in all of these. So CT perfusion base image showed evolving infarct in the left PCA territory. But in posterior circulation, we always do an MRI. So this was the CT perfusion.
Can you please explain to us this?
So if you see the upper window, this is the MTT, which is high. The blood flow is reduced in the PCA territory. The blood volume is maintained. So this means this is penumbra. In the second corner also, if you see the inferior, the medial temporal lobe as well as thalamus and part of hippocampus is showing high MTT, is also showing low blood flow, but the blood volume is maintained apart from some bit of blue tissue here. And the same applies to this section. So we compare this with this, only this of the tissue is core, and rest all is probably penumbra. And this was the base CT perfusion images, if you see. So perfusion gives us a better picture. So this was the CT perfusion. No, I don't see a very big infarct core. There was large penumbra. And this was the reconstructed image. A P1 left PCA was occluded at P1, P2 junction. So now we have a perfusion mismatch, a large vessel occlusion, and NIHSS of 2, at rapid improving weakness, thrombolysis, thrombectomy, or both. So we decided, obviously, we in all our posterior circulation strokes, we do an MRI diffusion imaging. That's so. So what would you do? Whether you would thrombolize, you would go for mechanical thrombectomy, you will only do thrombolysis, you will do both. What will you do?
Thrombolysis has to be done in any case. He was within window period, no, 4.5 hours.
Yes.
Yeah,
Okay,
we'll do
thrombolysis,
thrombolysis
yes. And
we'll do
mechanical
thrombolysis and
thrombectomy,
then
sir?
no, we'll think about it. First, we'll give if you give tenecteplase, it may thrombolize on its own. So what did you do?
So we
So
did
we-
give tenecteplase. We
If you
decided
can-
about thrombolysis, and we went ahead with the thrombolysis. And
So tenecteplase did not dissolve the clot.
no, sir, tenecteplase did not. So, and we were thinking about mechanical thrombectomy. Now, this patient has a low NIHSS. We considered the risk-benefit ratio. Like, it's not always successful. You might injure the vessel, then the cost. And we decided against mechanical thrombectomy, but she was having a low NIHSS. And so we did not go for mechanical thrombectomy. We just thrombolized the patient, and this was the CT the next day. So the patient has all of the perfusion mismatched area, which was on the first CT. She is already having infarction. The patient became a bit drowsy. The patient had a bit of hemianopia, and she also had the hand grip weakness increased further. There was facial palsy. There was some confusion. And this was the CT next day. So now if I ask you in retrospect, whether we should have done mechanical thrombectomy or not.
Yeah.
So mind you, the NIHSS is 2.
But you know, you're right. But I'll tell you one thing, Vinit. Even in the 2015 onwards, they said it is not just the NIHS which is important. It is important to see where the NIHS is coming from. So, which means what is the deficit? And here the deficit was vision because it was occipital. So, vision, aphasia, even if NIHS is 1 or 2, we have to take that. I would go by that law. That even though NIHS was low, but that low NIHS was coming from a very vital function, which was vision. So, this is a lesson for us.
So,
Sir, Vinit sir, in
yes.
our hospital,
That every deficit
just one
is
case,
serious.
in our hospital,
Even
what
if it was a
criteria
hand
we have kept is
weakness,
that,
that was also.
sir, in our hospital, what criteria we have kept is that less than 4.5 hours, they should not do MRI. I have strictly informed our team because it will save a lot of time. Because let us say the CTs was showing perfusion defect or no perfusion defect or whatever it is. I think the IV lysis was always on the card. So what we have done in our hospital is that only CT 4.5 hours and less CT and lyse. And then we can do it only when it crosses the 4.5 hours window. Then we try to do an MRI or any of those perfusion studies, ASL, whatever we do is subsequent to that. Maybe you could have saved time by doing only CT and straight away lysing and then sitting and thinking. Is that okay to think like that, Dr. Vinit?
So yes, so that is why I presented the case. I'm very glad you asked this question. So now NIHSS of 2, only minor hand grip weakness and facial palsy for a homemaker, if you consider whether we would have thrombolized or not. So it's like in low NIHSS, normal CT scan within window period patients. So probably yes, probably not. So probably we would have thrombolized. But then if we want to go ahead further, so you probably would need a vascular imaging. That is probably by a perfusion or an angio or whatever way. So even if we would have thrombolized, which we eventually did, whether we would have been able to save it or not. Now, this patient eventually did very well. She is absolutely back to normal. Apart from right hemianopia, she still has right hemianopia, a bit of numbness in hand. But other than these 2 complaints, she is absolutely fine. No
Vinit,
deficits at all.
my question to you is: you gave IV tenecteplase.
Yes, sir.
Gave.
Yes. Yes.
So the only thing you didn't do is mechanical. Now
Mechanical.
I'll tell you one thing. This actually I discussed this point with one of the faculty in some other session, that somehow we are not very tuned to do mechanical thrombectomy in PCA for some reason. We are tuned to do it in the MCA. We are tuned to do it at T junction. We are tuned to do it in basilar. But when it comes to PCA, for some reason, we think it is very benign. PCA, one of the small vessels. But we have to realize that, see, PCA, now you are to yourself saying that the deficit left is hemianopia. Now, hemianopia for a homemaker may be okay, but hemianopia for a driver or for somebody who has, it's a major deficit. So I think, yeah, that this is the learning here that probably, now this is the whole world is talking about low NIHS and this thing, but I think we should also think that low NIHS in her case is, the vision was at stake. Vision is at stake, which you didn't know at that time, obviously. It came later on. That's also very interesting.
So probably we did not had hemianopia in the beginning. And even if probably we would have had for an homemaker, as you rightly pointed out, it's less of a concern. And one of the reasons for not going into PCS and doing mechanical thrombectomy, sir, in my experiences, they are very prone for hemorrhagic transformations.
Yeah.
Very prone. So in those patients, even in where I have thrombolized and did mechanical thrombectomy, I have a lot of hemorrhagic transformation, and this causes a lot of mass effect on the brain stem and creates a lot of problem over time. So that's one of the reason I'm not very sure about going into PCS, especially if it is beyond P1 segment, P1, P2 junction. So I always think twice before going into it, probably because of my experience, or like one of the reason is brain stem is very near to it. Any mass effect leads to poor outcomes. So that's one of the reasons. On probably if this patient would have been a driver or something, I would have probably done mechanical thrombectomy here.
Yeah. Great case, really, very great case. So much of learning.
Sir, there is a gender bias. Even in a homemaker. To do it.
So Meenakshi, over to you. You can give your comments.
It's a really phenomenal case, sir. There's one more thing which I would like to ask you. Within definition, this has to be a posterior circulation stroke, correct, sir?
Yeah.
So if that is, will that NIHS typically apply here? That's one point we need to ask. Because the NIHS by definition was for the anterior circulation.
Anterior circulation. Exactly.
No. But NIHS in this situation will apply because NIHS may have been developed for anterior circulation, but the deficit which this patient would have could be measured by NIHS, no? Means hemianopia would come
major
also. Yeah.
Yes, sir.
There are some deficits.
And the second thing is that, sir.
Yeah, please.
Sir. No, sir. There are certain deficits. You're teaching us, sir. Yes, sir.
No, what I'm saying is there are some deficits of posterior circulation which NIHS is not capturing. For instance, NIHS will not capture nystagmus. NIHS will not capture internuclear ophthalmoplegia. But NIHS captures ataxia. And NIHS captures so grossly it would capture. But in this case, even NIHS would fail because she didn't have visual loss on that first day. And that happens sometimes. We have seen in posterior circulation stroke that they have, for some unknown reason, they get hemiparesis. So many times in PCS strokes, I have seen hemiparesis happening. And Vinit, it is possible that there might have had been some little subtle hemianopia which might not have been picked at that time, because in such a situation, a patient may not cooperate completely for a hemianopia. No?
True, sir. True.
Previously, we have discussed here about the PRISMS data also, sir, that whether we should really apply PRISMS data to our situation. And we have learned from Subhash Kal, sir, that whether there is low NIHS or NIHS, if it is a stroke, we give the choice to the patient. And if the patient gives the choice back to us, we thrombolize. We don't miss out on that.
Yeah, by and large, beyond these p-values and so much of statistical discussions and all, the common sense approaches. I mean, when you don't thrombolize, it is based on so many assumptions. In fact, if you read that paper, what is the definition of the non-disabling stroke? Definition of the disabling stroke is he able to wear his trousers? Is he able to shave? Is he able to do toothbrush? But that is not all what life is about. Numbness can happen on one side. Mild ataxia can be. I have Meenakshi has one patient who has got a severe numbness on one side. To this day, he's not forgiving him that why you didn't travel. I have got a patient who has got only lower motor neuron facial nerve palsy because of a brainstem infarct. His face remains crooked. I have got a patient who has got a cortical dysarthria. So these are also deficits. So I mean, the only fear of thrombolizing is that it may cause bleed, but that percentage of bleed is too less. And then one more thing, this is very funny. They are saying that when you are not thrombolizing a minor stroke, then you ask the patient or the attendant, and it's in the paper, that is it okay if this much deficit remains in your life? Is it okay? But the point is, there is no guarantee that the deficit will be this much. We know 1/3 of the patient progress over next 24 hours. So there are a lot of limitations. So based on that, most of us feel that when there are, even if there is a minor deficit, it's better to probably thrombolize them. Maybe with less dose or what, that Meenakshi only knows, but probably we should thrombolize.
Even in that criteria they have given, sir,
they
talk about we should exclude. Even the criteria they give, the hemiogalumpia exclude, all those things. The last thing is the most funny thing. Any residual deficit considered by the doctor or the patient as potentially disabling.
That's right.
So
that's
that gives the to do whatever that it is given in the guideline.
I know. And it is that residual deficit that time. They are not talking what the deficit will be after 24 hours. That is our only fear. It should not progress. And yeah. I mean, that's all I want to say. So
one more, that red flag which we see, sir, is when patients, our own colleagues, when the patient is improving, unless we fight, they wouldn't be initially ill. Now our hospital have taken up. Otherwise, our colleagues who come up, they refer from outside. If they are improving, they wouldn't be very happy about thrombolizing. Every time I quote them the paper about the risk patients, the rapidly improving stroke patients, where it is clearly mentioned, if you do not take up them for thrombolysis, the happy ending will not be seen. There is a good majority of patients, even in the US data with altiplase, who could not be discharged back home. A few of them who had so much, that is, they talk about the TGT, the too good to treat patients, where they talk about 128 patients, 41 of them having this wrist-like presentation. A few of them where the doctors felt we should not lyse them because they were too good to treat, they died. That was the definition of too good to treat there. So the rapidly improving stroke symptoms, in fact, should caution us that we should not lose our aggression in suggesting thrombolysis to them. Unless we are absolutely sure there are no symptoms left and the patient is completely normal, then there is a headache. There are patients whom we have faced, they are completely normal, but now we do a vascular. There's a question I need to ask interventionally. Sir, please teach us. We had patients we have a patient recently who had completely normalized after a stroke. Complete normalized within an hour or so normalized. But we saw a left MC occlusion looking like an acute, not an acute on chronic. So what will be your recommendations in such a situation if the patient has got an acute occlusion there, or we think it is an acute on chronic? Patient is normal within 1 hour, no deficits. What should we do at the patient, sir? Other than IV lysis, or whether we should go for IV lysis, zero NHSS, but occlusion?
No, I mean, if there is absolutely no deficit, means grade 5/5, then probably we should not thrombolize that patient.
I do agree to it. So we never do it. We keep a very close watch every 5 minutes. So what I do in these patients is I bring the relative in the ICU. I tell the relative to be with the patient in the ICU for next 24 hours. And if the patient shows even 1 grade deterioration in NIHSS, I take that patient up for mechanical therapy. Even 1 grade. So for example, a patient absolutely normal develops a facial palsy, mild facial palsy or dysarthria. Take that patient in for mechanical thrombectomy, because that's the first step which is showing that this patient either is having a fluctuating course or is having poor collaterals, or the collaterals which were good are not sufficient enough to maintain perfusion.
So I want to make one comment on that. Not on that, your point is well taken. No, Meenakshi, are you there?
Yes, sir.
Yeah. No, in these situations where, you want to give, but why we are not giving, other than the cost and all, we are a little afraid of bleeding, basically. Bleeding is the bugbear. They are afraid of, all of us are afraid of bleeding. Nobody wants a bleeding. No? On a nice, fine day or in the evening or in the night, you don't want a bleeding on your head. And that's what stops us from doing this. But You know, there are two situations I want to tell you where I have given TPA or tenecteplase now, even when the patient has become completely normal. And that was not as per guidelines, that was as per the situation. Now, I'll tell you which one. Capsular warning syndrome, in which a patient gets every hour one attack, every hour. And by the time we come with the thrombolytic, he has recovered. And the patient can get 50 attacks, 100 attacks. Now, it so happened that I told my resident that, look, give him, but don't give him during normalcy, because that is against guidelines. You be there. The moment he gets the attack, give him before he has recovered. Give him before he has recovered, so that you say that you are following guidelines. You know, and in fact, if you look in literature today, in capsular warning syndrome, people have been thrombolized, and even when they were normal. And some of them have done well, some of them have not recovered in spite of thrombolysis. But my experience in more than one patient of capsular warning syndrome is that after you have thrombolized these patients, even after thrombolizing, they have 1 or 2 attacks and then they have stopped. Many of them, at least 5 out of the 10, who were unstoppable. For 12 hours, they had 20 attacks. Then after 12 hours, you gave 1 shot of TPA, maybe even when the patient has improved. After that, either they stop having, not all of them, I'm again repeating, many of them, or they have 1 attack and then stop. Somehow it must be dissolving some thrombotic mechanism inside and not. Now, one of the things which I might do in these situations where I'm little afraid, that I give little less dose. Now, that may be a personalized approach, little less dose. There is a lot of data on less dose. Don't go by those trials which has shown. What was the trial? Some American trial which said that don't. Enchanted trial. But there are many Chinese trials, and our Bijoy Menon talks a lot about it, in which there's a definite role for low dose. One trial also they are being done, in which there's a definite role for low dose in situations, not in guidelines yet, low dose, but low dose in a high risk situation is okay. So, and I don't have a problem, because if it is TPA, I tell them give only 1 vial. And if it is tenecteplase, we don't have to worry about it, because tenecteplase in India is anyway low dose. So you just give the guidelines dose, which you are giving low dose before the new guidelines come.
Sir, Japanese pharmacopoeia, it is only 0.6 milligram per kg body weight.
Exactly.
They have accepted only that. They are not for 0.9. Yes. In the enchanted data, there was a side data which showed that this may be of benefit. Supposing a patient has been on dual antiplatelet therapy, and now he has come with exactly in the morning he has taken 2 doses. He comes maybe there by using a 0.6 milligram per kg body weight. Yes. You may get away by having a lesser instance of hemorrhage, reaping the benefit.
I think this is exactly what Vijay Menon is lecturing everywhere. So basically, we are in favor of thrombolysis.
In such situations, we use 0.2 of tenecteplase and not
correct.
0.2.
We agree. So I think we had great cases today, great discussion, great learning. It's 9:24. So any one of you can make any comment if you want before we hand over to organizers.
I think
thoughts from Dr. Vinay sir. Thank you.
I think Dr. Madhuru sir has left because of the network issues.
No, sir, joined again. Thank you. Yeah. I just wanted to add 2 points. I'll be very brief, sir. I just wanted to ask the other faculty as well if they have faced any similar situations. The last discussions have been very productive. In fact, I had similar experience with the capsular warning symptom and the rapidly improving stroke with the MCA cutoff, and where we had intervened and the patient had good outcomes. Again, nowadays there has been rapid use of newer anticoagulants like dabigatran, apixaban, and everything. usually before we go ahead with thrombolysis, it is our convention to ask whether they are using any cardiac medications. People are nowadays very well versed with ecospirin, clopidogrel, so they are very well answer acetylcholine warfarin. So for one patient, we had this discussion before we gave thrombolysis. We just asked whether he's using any cardiac medications. The patient told no. So we went ahead, gave the thrombolysis. But later on, the patient relatives have brought the list of medications where we saw that there was dabigatran patient was already using. So the reason for dabigatran that he was using, because he was having a chronic DVT and the patient was kept on dabigatran prophylaxis. So we just asked whether the patient was having any cardiac medications. Now, because the patients nowadays, they are little not much oriented to considering dabigatran as blood thinner. So we were just keeping our fingers crossed and then hoping that the subsequent day patient would not bleed. Luckily, patient did not use he defaulted his medications for more than 24 hours, and tenecteplase having less hemorrhagic complications did not have anything. We were able to save him. So one thing I'm very happy with the molecule of tenecteplase is that it has a significantly less hemorrhagic risk as compared to alteplase, even though even though the evidence says that it is almost equal. From my practical experience, I feel that tenecteplase has less hemorrhagic transformations. And with respect to the presence of large vessel occlusions, as during the second case of Dr. Vineet, PCA occlusions, right? So with respect to presence of large vessel occlusions, giving tenecteplase alone, I did not find much benefit, because even though we gave tenecteplase, patient ultimately progressed when there was a large vessel occlusion. So tenecteplase is superior or is comfortable in the absence of occlusion, and if at all in the presence of occlusion, it would give better reperfusion during the process of mechanical thrombectomy. But if you skip mechanical thrombectomy, the outcomes of the patient would not much differ. That's what I practically experienced. Any comments with respect to tenecteplase in the use of newer anticoagulants or availability of recurrent clotting time? That's what we usually read in the guidelines, but practically I don't have any centers which do recurrent clotting time when we in the places where I worked, at least.
So can I answer that, sir? Subhash. Sir?
Meenakshi, please comment. Meenakshi, please comment.
Sir, thank you. Sir, there is a recent paper which talked about DOACs. Earlier, we used to hear from interventionists and stroke specialists that when the patients are on direct oral anticoagulant, we have to reverse and then do it. For instance, if they are on dabigatran, you give iduricizumab and then give an injection. Now there is a paper which has come which talks about a large volume data. Patients on direct oral anticoagulants given thrombolysis. The harm is not in excess. So now we can accept. Only thing is that we need to tell the family that the patient has got a DOAC, and there may be a chance of hemorrhage which may be more than the 6% which we usually project. And the benefit should be there. That is why we are suggesting, if the family agrees, we can go ahead with that. This is with regards to...
So what did you say? What do we have to give?
We can give thrombolysis if the family agrees, because the
even in the absence of
even in the
absence of iduricizumab.
Yes, sir. That is a paper which has come recently, sir. I can share that. It's a large volume data they have presented, sir. That they have recommended that, though we were thinking about a hemorrhage risk in large, now this paper says that maybe you can consider that. But even if
the patient has taken the DOAC same day or yeah.
Okay. I don't know whether the same day or not, sir. We'll find out about that. That paper is there available in the net, sir. I think it's free.
Okay, boss.
They have given the paper that we can give it. Earlier, the author himself writes previously, Medware was also discussed about it. They say that previously we were thinking that we should not give it. But all these things, the data is based on altiplase data, sir. Because that is what the tenecteplase data is not there. I saw that. But that was the only difference.
Yeah.
So maybe there's a chance for us to think about it, but we do not know. I have not had the personal experience of thrombolizing even one patient on this one. Only thing we always ask for 40. This E-carrying clotting test, which is said, we went to talk to the hematologist. They said it is possible for them to establish, but the point they are giving the rider is that we should be giving them enough cases to sustain, which I don't think it is possible for us to do it, sir.
Yeah.
So we can't give them enough cases. The surrogate is PT and PTT. For all practical purposes, if a thrombin test is normal, they say that there is no dabigatran in the serum because thrombin test is highly sensitive, which is easily done. If the thrombin test is normal, then we can say dabigatran is not at that point of time acting in the system. So it can be used as a surrogate negative guide, but positive we can't say that. If it is abnormal, we can't say
But
how
is
much it is.
thrombin, but is thrombin time easily? Thrombin time also is not easily available, no?
That can be made easily available than ECAR in clotting test. ECT is much more difficult to establish, I am told, sir.
Okay.
I do not know, sir. We are not
Thank you.
experimental on that. Fortunately, we have not been in this trouble, really, sir.
Okay, thank you.
Thank you, sir. Thank you for the great discussion and the
Thank
nice
you.
case
Thank
presentations.
you,
It's a
everyone.
great
Thank you, sir.
learning opportunity that I've had speaking in front of you. I thank Emcure also for giving this opportunity and providing a nice platform for
Thank you. We
crosstalk.
enjoyed, we learned.
Thank you.
Thank you very much for it. Thank you, sir. Thank you, Vinit.
Yes, sir.
Thank you, sir. Good night.
Good night.
Yeah.
Good night.
Good night.
Good night, sir.
Okay. So it was a wonderful workshop, sir, as usual. And our online view count for today
is more than 110, and I'm sure our audience must have been benefited. We got to know many important things about IV thrombolysis as well as the endovascular treatment in stroke. And thank you everyone for taking some time out from your busy schedules on this evening of a weekend. And I would like to thank and congratulate Dr. Varun Rehani sir, Dr. Vinit Banga sir for presenting those interesting cases. And thank you so much, Dr. Kaul sir, Dr. Meenakshi Sundaram sir, Dr. Sumedha Mathuru sir, for your expert comments and your great practical insights. We would really like to work under your guidance for many such future programs, sir. So with this note, we will close this session. Thank you so much, everyone. Have a happy weekend.
Thank you.
Bye-bye. Good night.
Bye.
Thank you. Good night.
Thank you, sir. Thank you.